make people aware of research and work in those organizations. But please, you're welcome, Agnes.
Thank you very much. I was the president of ESPNIC, not now anymore. I'm now the chair of the, don't tell any further, I'm now a chair of a ESPR section, so I swapped. But don't tell them, to be transparent. Thank you so much. It's an honor for me to speak, and I think it's a topic of a problem we all face. What are we doing with our research? Even if it's very small, even if you detect a problem on your ward and you want to change it, it's quite different to convince people to bring the change into practice. And well, I'll try to give you an overview. I've nothing to disclose. This beautiful picture of the bridge here in Maastricht, and of course the bicycle, what we are all doing in the Netherlands, flowers. It's the same as Jos, who is in research today. That's what we ask. Can I ask a question? What are we doing in research? Is there somebody who has a specific topic here? This morning there was a lady, Marianne, about sleep. Some other topics? No? Sorry? Stress. Oh, that's great. That's what we are all want to explore, stress. And another question for me is very important. How does what we do reach our practice? How can we change practice with the results, as you said, the evidence-based stuff? How are we bringing this in practice? Jos showed another slide, but this is basically the same. It's from basic research to clinical research in order to improve health. Because we are talking very nice and can do everything, but when it doesn't affect or benefit our patients, why are we doing this? So this is for me really always my motivation. It's for the children and the parents we are working for. It's about translating research into practice. What do we mean with this? And it's here stated quite clear. It's a process where we pass knowledge anywhere along a translational pathway, for instance, research findings, but it can also be good ideas into practice, needs policy or further research. Why are we doing this? It's important. It seeks to make medical or nursing research process more efficient. It's looking for new ways to ensure basic science discovery, so it can lead to new interventions in order to adopt evidence-based practice. And to be honest, it's an exciting enterprise. And that's when you step into research. It's very exciting, it's challenging. I love it, that's why I'm here. What is the case in academic numbers, in the academic world? It's changing nowadays. A couple of years ago, in 2016, this was our dean from the Utrecht University, Frank Miedema. It's all about numbers. We have to publish, and who cares what we are publishing if we are publishing in high impact journals. And they changed this, or they did first steps, changing it by publishing this paper, Redefine Excellence. There's a battle ongoing. They said, what are we doing with our numbers? What are we doing when we publish much and it doesn't reach practice? It doesn't have any impact in practice. So he and his co-authors stated that we have to weight different to have input, not only on impact factors, but input in practice. And I always find this slide shocking. We have a lot of research waste. We are searching, researching, exploring things and finding new evidence for things, and it's never published. So this is a waste at 4 stages of research. Questions. We all have relevant questions and we want to figure out what's the answer. Are we using appropriate designs and methods in research? Is it accessible for full publication? Over 50% of the studies are never published in full. 50%. So that's half of it. Is half of it waste? Some are presented in abstracts, posters, like on this Congress, but it never is published in full. This is bias. Unreporting of evidence. What we are also not publishing is studies with disappointing results. My first publication was about let's talk a bit before. I did my PhD on infection and infection prevention and antibiotic resistance. And one of my first research was about inline infusion filters. And I didn't have the results what we were searching for, decreasing of sepsis in neonates. No, it was the same. We had other results, but it didn't decrease. The IV filter didn't decrease sepsis in neonates. It was so hard to publish, because what we want to see is that it works. This inline filter, we all should use this inline filters because it works. It helps to decrease sepsis. So a lot of our research isn't published because of disappointing results. And unbiased and usable report of 30% of trial interventions, if you read it critically, it's not sufficiently described. So that's also a waste, and not only the waste, 85% of our research waste is over $1,000 billion per year. I don't know how much it is. In zeros, I think I've never seen it, but be aware, this is what's happening in our world today. The battle is also in research, in pipeline. It's going from the leak, we call it the leaky research pipeline. Do we see? Oh yeah, okay, it's over here. They never published data, 50% avoidable research flaws, is unusable for incompletely reported data, 33% of evidence is ever implemented, also a waste. And if it's implemented, what's the percentages of sustainability? We don't even know. And you said 16 years, and it takes a mean of 70 years to get research evidence implemented. You have your pension by that time, right? I'm moving on, but Jos has his pension. Okay, so keep that in mind. That's the time it takes. And it's not even trials on new medicines. They take way longer. So how can we increase value and reduce waste? Well, perhaps you're familiar with the Medical Research Council framework, and I'll show you in a couple of slides. But this is a paper of a colleague of mine, Nienke Blijenberg, who studied how we can increase our research value and have less waste. So this is the MRC framework for developing complex interventions in healthcare, and it's really for all healthcare professionals, especially for us who want to change the world, to change our practice. It starts with development, identifying the evidence base, a theory, modeling process and outcome. And I know why we are not sticking on this model or any other model. It's way too much time. It costs enormous time. But if we see all our waste, and it takes 70 years to implement, why shouldn't we focus on the very beginning of this process to be more successful? When you've done that, you can do feasibility and piloting studies. Just testing procedures. estimating recruitment. How many do we need in our study? What's a power do we need, and can we reach that? So also determining sample size and perform a feasibility piloting. And then the worst thing of all, I think, is the evaluation. How successful was our piloting or feasibility study? Do we evaluate? We have a voice study, and the implementation didn't went well. And one of my peers said, you should do an evaluation. I said I did. And regarding this voice, it's a parent empowerment program. And they had some meetings with the parents. And all nurses said, we don't have any time. Ingrid just mentioned it. It's hard today. We don't have any time. And then my peer said, oh, go back and figure out why they don't have time. I said, well, it's a workload, there's hardly any staff, they don't have time. Well, I believe that. But going back and thinking about it, having time, interviewing them again, I discovered it's time. But it's also the moment. They are very good nurses at the bedside, and that's all about academic and having a level higher. What are you doing? They are very good nurses here and now. They take very good care of the infants, the parents, the surroundings. But empowerment of parents now gives better children later on, because there's less stress, they can handle it better, they see things earlier for interventions. And for me that was an eye-opener. So they didn't have time because they were very busy. But I say it's hard, they don't care what's beyond the NICU, because this is their job. And it's not for all nurses, but at that time, and busyness is a very good excuse. You are doing your work very good now, and who cares what's beyond the NICU? So this is evaluation. It cost me another 6 weeks of thinking. I did my work, but in my mind I was all the time thinking about that. And it's really good, because I can appeal now to the nurses and say, well, okay, if you invest in parents now, they'll care better for the children, and the outcome for the children is better later on. So this is the development phase of the renewed MSc framework, and yeah, you can read it in the paper, but it's very helpful when you're in the developmental phase of your intervention. What we did in early days, it was 2013, right, Jos? 2013, 2014, we did a Delphi study among European neonatal nurses to prioritize a research agenda and topics. What this study adds was that we developed an agenda after this study. And we identified these research priorities, and we were really amazed about the NICU top scoring. We did first the PICU and then the NICU, and about their scoring statements. Because we thought they all know how to prevent and to reduce pain or stress, right? There are so many papers about reducing pain and stress, we should know. Or strategies to reduce medication errors. And I don't know who of you was last night in the opening ceremony, but it's a very big problem. Medication errors still. End of life care in the families. I think when I'm reading this is boring. We all figured it out. But there's a need to do research on this. Strategies to support the needs of parents and families. And at the end, identifying best practice for pain assessment. This was the top 5. Guess which was number 6. Interventions to implement evidence into NICU praxis. Well, we were thinking, well, this is so old-fashioned, and we all know it. It still is a question to research that. We wrote a roadmap for nursing research in Europe, and we published it all. And then the big question, if we know that, what's going on in Europe? And what steps have we taken after these 2 papers? Everybody is in his own hospital, doing his own thing, figure out the things we know already, again and again and again. And talking about waste, I think that's also waste. Jos stated that we need to go together. This is beautiful, as we are sitting here, and this morning we had an ESPR meeting with a nursing and allied healthcare professional section to just combine our knowledge and put research and agenda on the map in Europe and globally. What we did after these 2 papers, it was presented in Melbourne? No, it was Sydney last year. And there we had the data from New Zealand and Australia. We combined it and we sent out a new survey globally. So what do we need knowing this, and what do we want globally? So it's understanding, exploring, and implementing it actually. What we did in our NICU, knowing this, it's systematic implementing things. We have a neo-stress team. It's about neonates and stress because my ward is about brain, so stress, brain, it's related. You have to be smart to do your research. As I told, I'm in infection prevention, it's still there, but how can I proceed as a researcher? So we were interested in sleep, and do we need ethical consent or make it very big? Well, let's review. What do we know of sleep in neonates? So we did a systematic review, and I had my neonatologist there, so multidisciplinary, some students, and it was published in, I think, within a year. So if you want to start small and you have some colleagues, start just a systematic review and get it published, because it's very important that we show our work. We can say we are doing the research, but if we don't show what we are doing, how should the world know? So from this systematic review, we found interventions to promote sleep, and this is what you can implement. Besides the kangaroo care, you know, everything has to connect it with the brain. So how am I exploring kangaroo care? Well, connecting it with the brain and see if there's a better outcome. Also, music therapy and interventions. This is what we are doing now on our NICU, and we should tell the world to connect and do it together. So why do we change practice? As I said before, it's a challenge. And the first question is, do we need it? Do we need to change our practice at all? So that's the first question. Is it important? Do we need it? And then the second very important thing is define what will be achieved when changing practice. Is it better outcome? Is it better care? But also, is it money? I changed last year the culture policy in our, not the culture, but the cultures from the swabs and the blood cultures in our unit, and it delivered a lot of money. And now I'm doing the evaluation. Is it safe? We did it before, and now after a year, is it safe? And it is safe, I can tell you already. My boss I need to tell my boss, but first it's safe. And we save a lot of money, and it's also very important to show that. Show why it is important. And another, it's point 4, but it's very important. Does everybody support your idea? Because when they are all against, you won't have any success. So you have to you need support. Well, why do we have translation into practice? Through the translation of evidence, patient safety will increase and care responses can be recalibrated for the benefits of our patients, but also for our staff. If we are very busy and we have interventions which can make us less busy on the ward, it's a benefit. We need strong evidence, and translation should be considered in good research design to don't waste our research. So what is implementation? If I use it in Google, it's always a kind of vague thing, but it's the carrying out, execution of practice of a plan, a method, or any design model for doing something. So it's an action that must be followed at any preliminary thinking. Critical needs to increase the number of high quality systematic reviews. As I said, yeah, to be honest, I'm a teacher in systematic review. I'm very much in favor of that because there is a lot of evidence, and when we combine it, just recently, we can show effectiveness of that. And there's within the Cochrane collaboration a group of effective practice and organization care group, which we can all use. However, if we don't report it in a proper way, it's not good, because when we assess your paper and we can't see how it is done and there's no transparency, it's also a waste. So there are several measures to report it, and this is one for reporting guidelines, but it's also for reporting papers. Use them to give insight in what you've done and how you did it. So this is the STARI, this is Standards for Reporting Implementation Studies. If you follow this, it's very clear to follow, and it's step by step, makes you write good papers. Talking about waste, what we did is in the European Union, European Standards of Care, you all heard it from EFC and I, we developed 11 standards, 11 years? Yes, 11 standards of care, and we worked on it, I think, for ages, for 5 years. It was European money, so you're quite responsible. There are 11. I was on education and training, but there was an ethical one. Well, go to the website and you can find it. There's nowadays a toolkit, Shaping the Future, and they are published on the website, and that's it. So how are we moving on now to implement these standards in Europe? And that's really the question. Step by step, country by country, we have to pick up how are we going to implement these standards. So that 5 years with a big group is not a waste. There is a nice book, How to Change Practice, and that's very good. If you are in your own unit and you want to use that, go to this book. It's also on the website, How to Change Practice. Very pragmatic. It's providing national guidance on the promotion of good health, and it ensures high standards of patient care and patient safety in line with the best available evidence on clinical and, again, cost effectiveness, because that's very important. You can't have the one and losing the other. This is the content of the NICE. Understand barriers to change, identify them, and overcome them. And it's really a challenge. Change and challenge, it's almost the same, but it strongly belongs together. So in on this website and in this book, there is this, that we understand the barriers, awareness and knowledge, skills, acceptance and beliefs, practicalities. How can you identify the barriers? There are several tips and tricks. Brainstorm, run focus group, Others do use a questionnaire, talk to key individuals. What we did, family-centered care in my unit, we want to implement it, and we think we implemented it, but it's not, you know, there's a lot of resistance, although everybody is thinking he does. So one of my students was in Sweden, Norway, and a center in the Netherlands, and she explored factors that influenced implementation in family-centered care in these different centers. And her conclusion was, it's a change of mindset. It depends on the mindset of healthcare workers that their primary caregiving is changing in another role, a role of coach to the parents. So this helps to understand what is going on and what we need to implement our interventions. And this is a chapter of how to overcome the barriers to change, and these are keywords: be proactive, practice transparency, appeal to reasoning, own the change yourself, have your ownership, be the owner of the changing, and encourage others to co-own the change. So translating research into practice. This is Aristotle, and I totally agree. The route to successfully change is the habits we create for ourselves, for our parents, for our children. It's achieved by consistent small changes. You know, for me as a nurse, I'm here and I want to be there, and as fast as can be. But doing research, implementation of science into practice, it's small steps. But we are moving forward, small changes, and we are what we repeatedly do. It's an appeal to you all. Excellence then, it's not an act, but a habit. Thank you very much. It takes a touch of a genius and a lot of courage to move in the opposite direction. And the